Thank you, sir. Thank you.
Now next we invite Dr. German Bianchi, who is going to talk to us for his experience of 7 years with an IPCL. When the IPCL was introduced, the first Indian phakic IOL, I think that changed the whole of the scenario in our Indian market, that how the IPCL is being used today.
Okay, good morning. Thank you very much for your invitation. I'm very proud to be here in front of you. Today I will talk about my experience, my 7+ years about IPCL. I start with IPCL 7 years ago, and today this is the resume of my talk. This is the resume of my experience about IPCL. I started with the model V1, after that with the toric version and V2, and I have some presentations around the world because when I start, I didn't found any publication, and this was my first publication about the model V2. With just 6 months of follow-up, I found very safe IOL. The endothelium, the CCT was really stable after 6 months, the VOL2 and the IOP2. And also it was very secure for the refraction too, with very good results. And also I realized that the volt not was just a number. The volt is a dynamic parameter. And I found in different light conditions with photopic and exotopic with different intensity of light that the shifting of the volt is slightly lower than 100 micron, and it's different another IOLs like ICL or the biotech. And well, it was presented like a peer review. Also, this is another study that I did, the presbyopia management with the diffractive phakic posterior chamber IOL. This is the first IOL that work together with the crystalline lens. It's a diffractive IOL that work together with the residual accommodation of the IOL. And this is the focus curve. And also you can find that when I did this study, I also present this nomogram because I didn't know at that moment how to correct the presbyopia in this patient. And I realized that it's not dependent only the age of the patient, dependent also the myopia of this patient. And in the majority of my patient, I did the blend. In the dominant eye, I put the most addition that the patient tolerate, and in the non-dominant eye, I put a little bit more addition. And when the patient don't tolerate, I put the same, but the most addition. Could you put the sound, please? This is a lady after 48 hours of the second eye that I did the surgery. Well, they said in this real, believe me, that she said that she don't feel halos, she don't feel anything, and she can have very good far and near vision. You can put sound, please? No. Okay. It doesn't matter. And this is my own technique that I use to introduce the IOL, the hydroinjection on phakic IOL. I also published this technique. And for me, it's a very good technique because I don't found any peak of IOP after surgery. I use this irrigation cannula with the 20 gauge, and after that I did the 2.8 millimeters main incision, and I inject the lens under irrigation. All of my patients have this kind of surgery. For me, my technique is very safe, and I don't have also cataract, and I never broke the anterior capsula with this way to do the surgery. This is also the real time of this surgery. Also, I realized the cyst prevalence. I realized that there is a lot of cysts in my population, and I found this cyst, and the prevalence is near of 50% of my patients. And also, 82% of my patients were bilateral with the cyst in both eyes. Also, I present in ARVO the last year And I found that the very real vault between 400 and 600, this patient don't have cysts. The rest of the patients have more cysts and are out of this very good vault. And also I realized that the patient that has more than 750 have cysts in sulcus. Also, we know that there are differences between ICL and IPCL, and this is a new study that I made and realized that with 5 years follow-up, I realized that the vault was very stable in all of these patients, just reduced a little bit when the vault is more than 750. And also, this study is about the endothelial cell density, and it's very stable after 5 years, and also the intraocular pressure. Also, I did this surgery in some extreme case, like this, with minus 31 and with the cylinder. You can see here that this, the surgery and the thickness in the periphery of the optic is thicker than the other lens, and you must take care in these cases because you need anterior chamber and the angle between the iris and the cornea a little bit more than the other patient. And it was with very good result, very secure. And in this case, we can see the central vault and also the peripheral vault is very important too. And well, this is the same picture. And also I did the surgery in some emmetropic patients. And this is not the normal, but sometimes comes people with 50 years, 45 years with emmetropia, and I used to put this IPCL to correct the presbyopia with very good result too. This is with sun. You can see the subtitle there, but this is a man with 50-year-old, the IOL with plus 0.5. And in the dominant eye, I use the addition of plus 2. And in the non-dominant eye, I put the addition of plus 3. I asked about if he can drive at night, and he said that they don't have any problem about that. And also he improved the visual acuity for far vision, more than 20/20, and for near vision, Jaeger 1. And I think it's an option, but it's not for every patient. We need to know how is the angle and how is the anterior chamber, and in a metropic patient is not always a good patient for that surgery. But also we need to learn about our complications. Every doctor that makes surgery has some complication, but I have just the 3% of my patients. The most common complication was the rotation of the toric IOL, and I realized that all of these patients have cysts in sulcus. This was, for me, one of the reasons because of that. This is the lesson learned for this complication. And also low vault. Low vault is not just a number like I said before, because it's an adynamic vault, because depends on the light condition. And some patients I need to take, and this is another complication, the high vault. It's happened. Sometimes the capture of the pupil could be you need to exchange in this patient. And also sometimes I found cataract. The 3 patients that I have cataract was the model V1 because of the vacuum, because this lens don't have the central hole. But the new model has the central hole, and I don't have any complication with cataract in my patients. Not every patient that has cataract, you can take out the IOL, because we need the central hole is very important because the viability of the epithelium of the anterior crystalline lens is very important for the diffusion of the aqueous humor. Cataract is not caused by the lens material, but we need the circulation of the humor aquosus in these places. And, well, this is the complication, 10 eyes, 3 eyes with rotation, 4 eyes with low bolt, 3 eyes with cataract. And the low bolt is important, but I have patients with low bolt and without cataract with the model V2. And, well, we need all of this information, and we need to know that it's very easy to remove the IOL. The model V2 I take from with the cannula from the hole of the optic outside, and it's very easy to take out in that way. And with 1 or 2 McPherson you can take out. In this case I take with 2, and it's very easy to remove. And in the same procedure, I inject underwater the IOL. And this is another video from the model V1, just this similar surgery, but in this case, this model don't have the hole in the optic, and I take out with the forceps from the optic, like you see here. And with, in this case, with 1 McPherson. Well, the important thing is that from all of my patients, I just have 3% of complication. This is very important, the pre-op study and the post-op follow-up. I think that the UVM is one of the most important studies, that because we need to know how is the anatomy of the sulcus. That is the place that we need to put the IOL. 7 years ago, I trusted the company and the IPCL, but nowadays I have evidence-based medicine to prove it that the IPCL is very good IOL for correct high myopias. This is the congress that I am a director in Cordoba. The name is Ophthalmo Cordoba. You can take a picture of the code, and you can join us in this congress by streaming. Thank you very much for the invitation.
Thank you. Thank you, Dr. Bianchi. Very nice presentation and very nice details of the procedure and the complications. So that's a highlight of it. So you know that what complication you make it and how to rectify those complications. The one thing that you showed of that diffractive IOL that you put for you said the difference was in a 0.5.
Sorry.
Difference of a 0.5 diopter in 2 eyes?
When I used the diffractive IOL, yes, I used to put the difference between the dominant eye and the non-dominant eye. I used to do that, and I have very good result in my patient. I used to put the most addition that the patient tolerate in the dominant eye, and I put a little bit more in the non-dominant eye, plus 0.5 or plus 1. I have a very good result with that, and sometimes I use the same addition in both eyes when the patient don't tolerate the addition.